Joga Ivatury is one of our chief residents and will be talking on benign anorectal disease. Dr. Ivatury grew up in Virginia, around Virginia Beach. He went to Virginia Commonwealth undergraduate and then went to the medical school at Richmond, where not only did he get his MD degree, he got an MHA in hospital administration. And then came here for his general surgery residency. Joga, present.
Thanks.
Pleasure to have you.
So I'd like to talk to you today about some benign anorectal disease. Part of this is so that for the abside and for also just general knowledge. So I want to focus really on brief anal anatomy and physiology. We'll talk about anal abscess, fistulas, fissures, and hemorrhoid disease. We won't talk about other benign disease, specifically like rectovaginal fistulas and incontinence and things like that, because these are things when I look back at what we've been tested on, these are the topics that are probably the most relevant here. So just looking basically at the brief anatomy of the anorectum, it's important to know that from the anal verge to the dentate line, it's about 1 centimeter, and that's kind of the anatomic anal canal. Up to the levators, the anorectal ring is about another 1 to 1.5 centimeters, and that's what we consider the surgical anal canal. Here you can see some of the vasculature, as well as here's a better picture looking at the levators with the internal, external sphincters, the dentate line, which is a transition from sort of columnar epithelium to more squamous epithelium of the anoderm. Also, when talking about benign anal anatomy, it's also important to understand the potential spaces that exist. Here is the ischio-anal fossa, the perianal fossa, the intersphincteric space, the supralevator space, and then if you see on a different cross-section, you can see the deep and superficial post-anal spaces as well. Briefly, when talking about anorectal physiology, it's important to talk about continence. And what continence is a balance of the propulsive forces, which is interabdominal pressure and peristalsis, and resistive forces from the pelvic floor and sphincter muscles. Then the muscles of the pelvic floor and sphincters, the levator ani with the pubococcygeus, iliococcygeus, ischio-coccygeus, innervated by the sacral nerves. The puborectalis is a very important component in terms of continence. Then you also have the internal anal sphincter, which is an extension of the inner smooth muscles of the rectum, and the external anal sphincter, which is striated muscle, which is under voluntary control. Also, it's important to note the anorectal angle, and if you see here, you have the puborectalis muscle, which causes an anorectal angle, which also assists in continence. When you have relaxation of the puborectalis angle, you have straightening of the anorectal angle, which then allows one to have to be able to defecate. So let's first start talking about anorectal abscess. Again, looking back at the potential spaces, you have the perianal space, which is the area of the anal verge, the ischio-anal space, which is from the levator ani to the perineum, the intersphincteric space between the internal and external sphincters, the supralevator space, which is above the levator ani, and the superficial and deep postanal spaces, which between the coccyx and the anococcygeal ligament, as well as the retrorectal spaces. Anal glands are important in terms of the pathophysiology of anal abscesses, and at the dentate line, the ducts of the anal gland empty into the anal crypts. Some of them empty submucosally. Most empty submucosally, some extend into the internal sphincter, some into the conjoined longitudinal muscle, some to the intersphincteric space, and some penetrate the internal sphincter. The etiology of anorectal abscess is most common cause of anorectal abscess is due to nonspecific cryptoglandular infection, resulting from obstruction of the anorectal glands, leading to stasis, infection, and formation of the abscess. Predisposing factors include diarrhea and trauma from hard stools. The diagnosis of anal abscess, people have symptoms and signs of severe anal pain, malaise, swelling, purulent or bloody drainage, fever, urinary retention. And for patients with Crohn's disease, anorectal abscess is a presenting symptom in 10% of those patients. On physical examination, there's pain on exception or examination, and diagnostic tests demonstrate elevated white blood cell count. And usually imaging studies are unnecessary unless it's involved in complex abscesses where a CAT scan may be beneficial. So in general principles is obviously for any abscess, incision and drainage is a hallmark. The patient is put in a prone or lateral position, injected with local anesthesia, and elliptical incision is made in order to fully drain this abscess. This is specific for ischioanal abscesses. Other abscesses, such as horseshoe abscesses, a horseshoe abscess is an abscess that really originates from the deep postanal space and kind of is a horseshoe. The Hanley procedure is where one makes a midline incision and then counter incisions in order to fully drain the sort of horseshoe abscess. Similarly, supralevator abscesses are very complex. It's also important to determine the origin for supralevator abscesses in order to not prevent fistula formation. In the left picture, you can see that the origin is from an ischioanal abscess. Therefore, you drain through the perineum, because if you drain it through the rectum, you'll create an extrasphincteric fistula, which we'll talk about fistula disease next. In terms of the right picture, you have an intersphincteric abscess. In this case, you drain these abscesses through the rectum and not through the ischioanal fossa, or you would create a suprasphincteric fistula, which we'll talk about as well. Special considerations in treatment of anal abscesses are in patients with HIV and AIDS, where IND and catheter drainage is still something that's important, but it's important to also keep the incision small and use adjunctive antibiotics. In this patient population, it's been quoted that the perianal sepsis rate is about 13%, and don't forget about a potential for neoplasia. In patients with hematologic disorders, it can be a significant morbid and cause significant mortality, especially for patients with leukemia. It's important for the oncologist to keep the neutrophil count up. As it's demonstrated with the neutrophil count above 500, the incidence drops tremendously in terms of the origin of anorectal abscess. Surgery is generally avoided, as well as digital rectal exam, and it's important to treat them with broad-spectrum antibiotics. Next, we can talk about fistula and ano. Does anyone know who this is? So that's Louis XIV. Louis XIV was a French king in the 1600s. He was in his 40s and was diagnosed with an anal fistula. He had his major, at that time there was a division between physicians and surgeons. Surgeons were barbers. They weren't really at the same level as where medical physicians were. And so he had all his royal physicians come and try to treat his anal fistula with different potions and creams, and with no success. And then Charles Francois Felix was a barber surgeon that started to talk to the king about the ability of doing a surgery to try to treat this fistula disease. And initially the king said, I don't want surgery, and it continued this non-operative sort of potions and cream management. And eventually the king became so frustrated because he was very unhygienic. He had to use many perfumes to try to cover his smell and things like that, that he decided to take Charles Francois Felix on his offer, but he wanted them to try it on peasants first. So Charles Francois Felix did these fistula operations on peasants, many of which who did not survive, but they were quick to put the bodies away before the king noticed that they didn't survive, and then perfected the technique of fistulotomy. And he took, basically on November 18th, 1686, took him to the operating room. So, and basically did an operation on him, and about 8 weeks later, the king was fully cured. The king said, we'll give you, land and everything like that, but Francois Felix also said, in addition to all these things you're giving me, I want you to have a royal decree to separate Barbary from surgery, and make surgery something separate from just Barbary. And so the king decreed that we would separate Barbary from surgery, which led to partly to the development of surgery as a noble profession in addition to medicine. So this is a story that kind of helps with our profession here. Fistula and ano is an abnormal tract or cavity communicating with the rectum or anal canal by an identifiable internal opening. The etiology is secondary to cryptoglandular infection, such as those patients with anorectal abscess. The classification, the most common type, is an intersphincteric fistula that results from a perianal abscess. The tract passes within the intersphincteric space and goes into the rectum. Transsphincteric results from an ischioanal abscess and pass through the internal opening through the internal external sphincters into the ischioanal fossa. Suprasphincteric results from a supralevator abscess, and a tract passes above the suprarectalis after arising from an intersphincteric abscess, and an extrasphincteric abscess is one that passed through the levators. So you can see here Like I said, the intersphincteric abscess goes through the intersphincteric space into the rectum. Transsphincteric is from an ischioanal abscess. It goes up and then goes through both sphincters. Extrasphincteric goes through the levators, and suprasphincteric goes through the puborectalis and then comes through the internal sphincter here. The clinical evaluation is obviously important to obtain a history of anorectal abscess. Signs and symptoms include drainage, pain with defecation, bleeding, swelling, and decrease of pain with drainage. In physical examination, you may notice an external or secondary opening, which may be draining purulence, and then there's also an internal or primary opening. This is Goodsall's rule, which is important for, obviously, for examinations. It's when a patient is placed in a prone position, a transverse line is drawn. For abscesses that are for fistula external openings that are posterior to this, the internal opening is likely in the posterior midline. Whereas if for anterior to this line, the internal opening tends to be radially oriented. But the exception is when you have a significant distance from the anus is where one can have an exception to that rule. Goodsall's rule studies have demonstrated that the posterior component of Goodsall's rule is actually very accurate, but the anterior component may or may not be as accurate as initially described. And actually, the fistula opening can be in the anterior midline. Preoperative investigation is with anoscopy, sigmoidoscopy, or colonoscopy, especially when you have suspicion for inflammatory bowel disease. Fistulography, CAT scan, endorenal ultrasound, and MRI have all been described and used for fistula disease. Here's an example of an endoanal ultrasound where an ultrasound probe is placed intraluminally. You can see here that injection of hydrogen peroxide tends to light up the fistula tract. There are three major principles for fistula treatment. The first is to eliminate the fistula. The second is to prevent recurrence. And the third is to preserve continence. It's important to identify the internal opening. This can be done by a passage of probe from the external to internal opening, injection of hydrogen peroxide, milk, methylene blue, and following the granulation tissue. Here's an example of a probe that's placed from the external opening to the primary or internal opening. There are different methods of fistula treatment. The first method is just to identify the opening and then open it up, or the lay open method, which can be used for simple and intersphincteric and low transsphincteric fistulae. The technique is to place the patient in a prone position, inject local anesthesia, place the probe through the fistula, unroof the fistula, and then do plus minus marsupialization. The recurrence rate has been quoted to being about 4 to 10%, with an incontinence rate about 10 to 15%. As you can see, the probe is placed from the external opening to the primary opening. The fistula is open and curetted, and then it's marsupialized here. The next treatment is a ceton treatment, which can be used for high transsphincteric fistulae and important for anterior fistula in women, patients that have HIV and AIDS, and those that have Crohn's disease. The technique is similar in that you place the patient in prone position and inject with local anesthesia. The lower portion of the internal sphincter and skin is divided to reach the external opening, although I'll show later in a study that this is now being questioned. Non-absorbable suture or elastic sutures are inserted to the fistula tract, and the ends of the suture are tied with multiple knots to increase handle for manipulation, and the ceton is subsequently tightened. This is where a cutting ceton, which then the ceton slowly cuts through the sphincter and allows healing above where it had cut through prior. The draining ceton is a ceton that can be left in place and promote drainage. And here's an example where the internal sphincter is cut, and you can see that the ceton is placed here. The next option, and for ceton, the recurrence rate is about 5%, but incontinence rate has been shown to be as high as 50% for cutting ceton specifically. Next option is a bioprosthetic fistula plug, or this is lyophilized porcelain submucosa, that's used for long fistula tracts without active sepsis. The fistula tract is identified but not debrided. A probe is placed, and secured to the end of a probe is a suture and the plug is pulled from the internal opening to the external opening and then secured on the internal opening with a figure-of-8 suture. The plug is then trimmed at the external opening, and this opening is left to drain. Recurrence rate is fairly high with this, about 50%, but since no sphincter is actually cut, it virtually has a zero incontinence rate, and you can see a plug being inserted here. The next option is an anorectal advancement flap. This is used in specialized situations such as anterior fistula in women, those patients with inflammatory bowel disease, patients with complex fistula disease, and patients with previous sphincter operations. This is even a more intensive operation. A full brow preparation is done. The patient is placed prone with a Foley catheter. The identification and curettage of a fistula tract. Then a flap of mucosa, submucosa, and part of the internal sphincter is made. And the residual internal opening after you raise this flap is closed. And the flap is advanced. The part of the mucosa and submucosa that had the fistula is removed and then sutured in layers. So you can see here that the fistula tract is identified and curetted. Then a flap is created. The internal opening here is closed. This area is removed, and the flap is advanced. The last option is a ligation of intrasphincteric fistula tract, or a lift procedure. It's used for high transsphincteric fistulae. The technique is to identify the internal opening, incision at the intersphincteric groove at the area of the internal opening, dissecting through the intersphincteric plane until you find the fistula tract, suturing and removing the fistula tract, curetting the external opening, and then suture closing the external sphincter muscle defect and internal opening and closure of the intersphincteric wound. So you can see here the internal opening is identified following an incision at the intersphincteric groove. This is taken down and the fistula tract is identified and suture closed. The area is then curetted. Then the external sphincter is then reapproximated and the skin is closed. Special considerations in treatment of fistula are those patients with Crohn's disease specifically, where the fistula is the most common perianal manifestation. The goals of treating fistula disease in patients with Crohn's is to alleviate symptoms and to preserve continence. In terms of conservative management, it's important to be conservative with these patients because it's been said that the incontinence is likely related to aggressive surgery rather than aggressive disease. In patients with HIV and AIDS, it's a prevalence of fistula disease in patients that engage in anoreceptive intercourse. They obviously have delayed wound healing, and retroviral therapy is used to prevent perianal sepsis. Asymptomatic fistulae actually require no treatment in patients that have HIV and AIDS, but the treatment is usually a fistulotomy for low intersphincteric or low transsphincteric, as well as or draining ceton placement. When examining studies specific to every different type of treatment, for the lay open method, it's always important to say how much sphincter can actually be cut, because you're cutting through some of the sphincter when you try to open this fistula. And in a recent study, there was a prospective evaluation on patients undergoing simple fistulotomy, where they did 3D endoanal ultrasound before and 8 weeks after fistulotomy. They had 36 patients that had very low transsphincteric or intrasphincteric fistulas with no prior history of incontinence. Good news is they had 0% recurrence rate, but what they found was that if you divide more than 2/3 of the external anal sphincter, that there was increasing levels of incontinence and soiling for those patients. So roughly about 2/3 of the external anal sphincter in the lay open method is associated with a higher decrease in their fecal incontinence scores from preoperative. In terms of ceton placement, to divide or not to divide the internal anal sphincter, a recent study in 2010 examined this. They looked at a mix of studies from a review, about 18 studies with 448 patients. They found that recurrence rate really was not statistically different from the sphincter division versus sphincter preservation. However, in those patients that had internal anal sphincter division with their ceton placement, that they had a much higher rate of incontinence in those patients. And here is an example of how the various methods that one can use a ceton, different materials that can be used, the maintenance of tension, variety of technique, as well as with sort of draining cetons in a study that from August 2012. In terms of fistula plugs, there was an examination of outcomes of fistula plugs for patients that had Crohn's and non-Crohn's related fistula and ano. There was another systematic review for 20 studies of 530 patients, the majority of which had cryptoglandular etiology for their fistula. The plug extrusion rate was about 9%, but fistula closure rate was a modest 54% for both patients with Crohn's and non-Crohn's. The authors concluded, though, that because they only had 42 patients with Crohn's disease, that this did not, they would not advocate for using plugs. This is not something that will say you absolutely have to use plugs for patients that have Crohn's disease because of the low numbers. In terms of anorectal advancement flaps, the examination of advancement flaps for patients with cryptoglandular or Crohn's, fistula, and ano. This is an examination of a systematic review over a 30-year period for anorectal advancement flaps, the majority of which, again, were cryptoglandular nature of fistulae, 91 with Crohn's and 228 that were unable to be identified. You can see that fistula closure rate was higher with those patients with cryptoglandular disease compared to Crohn's, 80% versus 64%, but the incontinence rate was not statistically different in these patients with cryptoglandular having about 13% and Crohn's have 9% here. In examining the lift procedure, it's a very relatively new procedure, and there's a pilot study in 2012 examining outcomes in the short term. In 40 patients in an 18-week follow-up, they had about 90% success rate with fistula closure. However, a larger study with a median follow-up of 19 months showed that the lift procedure had only about a 40% success rate with a modest improvement if you had a repeat lift procedure or an intersphincteric fistulotomy added as well. So next we'll talk about anal fissure. Anal fissure is an oval ulcer-like longitudinal tear in the anal canal distal to the dentate line. It's usually in a younger population, and the location tends to be in the posterior midline. Anterior midline is another next common orientation, with a posterior anterior midline being about 3%. Lateral fissures should concern you for Crohn's disease, TB, syphilis, or other infectious diseases. And the etiology, when basic scientists studied this, was from sphincter hypertonia, and also decreased rectal blood flow in the posterior midline, which then makes the posterior midline susceptible to ischemia. So you can see here on this cartoon that posterior and anterior are typically the nature of benign, acute, and chronic anal fissure, whereas lateral, when a patient is placed in a prone position, makes one concern for a Crohn's or infectious-related fissure disease. Clinical evaluation from symptoms, they typically result in pain during and particularly after defecation. They feel like razor blades or broken glass on their anus, and there may be a history of passage of hard stools. They're readily diagnosed with external anal examination, and further invasive examination should be deferred. So one should just spread the butt cheeks and be able to see, usually in the posterior midline, that you see a fissure, and you can see a fissure here. Additionally, there may be a potential for a sentinel skin tag or hypertrophied anal papilla on exam under anesthesia when you can actually see a fissure disease. Management for anal fissure disease, actually conservative management, is actually fairly successful with a 50% success rate, where patients are instructed to take psyllium, sitz baths, and use topical analgesics and anti-inflammatories. So that's the first-line treatment for any patient that comes in with anal fissure disease. Following this, one can try sphincter relaxants such as nitrates, which have had modest success about using that nitroglycerin ointment applied 2 to 3 times a day for about 4 to 8 weeks. The side effects from nitroglycerin do preclude it from being a good option because patients tend to get systemic absorption and get headaches with regards to nitrate treatment. One can also use calcium channel blockers such as 2% diltiazem cream, which tend to have less side effects than nitroglycerin, as well as botulism toxin. Operative management, anal dilation is something that's more historic in nature. The 4-finger method, or using a protractor, opening it to about 4.8 centimeters or 40 millimeter mercury balloon, has fallen out of favor due to inconsistency of treatment. Really, the gold standard is lateral internal sphincterotomy, which is a division of the internal sphincter up to the level of the dentate line. Tailored sphincterotomy, which is along the length of the fissure, is another method which is some use rather than routine to the dentate line. There are 2 methods of sphincterotomy. One is an open sphincterotomy, where one actually makes a lateral incision, finds the internal anal sphincter, and divides it, or a closed sphincterotomy, where a Levin blade or a Bleaver blade is introduced in the intersphincteric space, and you divide the internal anal sphincter. Here's an example of an open sphincterotomy, where an incision is made, the internal sphincter is divided, and then the anoderm is closed. And then the closed sphincterotomy, where the intersphincteric groove is identified, a blade is introduced and turned, and you can do the lateral to medial or the medial to lateral method to be able to divide this. Tailored sphincterotomy would then also only take this up to divide the sphincter up to the level of the anal fissure. Studies have suggested that closed sphincterotomy has less incidence of incontinence and seepage compared to open sphincterotomy. special considerations in patients with anal fissure disease. Patients with Crohn's disease, anal fissure is about 25% of patients with Crohn's disease have anal fissure as their presenting perianal manifestation. Proceed with caution in these patients and start with conservative management first. Attempt to tailor the limited sphincterotomy, and topical agents have not been studied in this population. In terms of HIV and AIDS, there's a paucity of data with 32 patients, but although 32% of patients with HIV have a fissure. There have been very small studies that have suggested that sphincterotomy is safe in this population, but this has not been studied in a large method. In examining fissure in ano, there have been randomized controlled studies that have looked at controlled versus traditional versus tailored sphincterotomy for chronic anal fissure. In 2005, they examined 225 patients and randomized them to either traditional or tailored sphincterotomy. Recurrence was pretty low for both groups, 1 in the traditional and 0 in the tailored sphincterotomy group, but incontinence was higher when more of the internal anal sphincter was cut, up to 10%. 10% for the traditional sphincterotomy group, which then suggests that the tailored sphincterotomy group may be a better option. In terms of all systematic review recently that has come out on operative procedures for fissure and ano, there was a review of all operative procedures, and the authors concluded that anal dilation should be abandoned, like we have talked about before. But overall, operative success rate is pretty good. It's about 90% with about a 5% incontinence rate. Last, we'll talk about hemorrhoid disease. Hemorrhoids are cushions of highly vascularized anal canal tissue in the submucosal space. They contain blood vessels, elastic tissue, connective tissue, and smooth muscle. Traditionally, they say that there's the left lateral, right anterior, right posterior hemorrhoidal complexes. Some vessels lack a muscular wall, and they act more like sinusoids. Hemorrhoid bleeding is arterial from these sinusoidal arterioles, and they're associated with continence. Hemorrhoids are important in order to help with the resting anal pressure and contribute about 20 to 25% of resting anal pressure. As you can see here, you have internal hemorrhoids, which are proximal to the dentate line, and external hemorrhoids, which are distal to the dentate line. The etiology from hemorrhoidal disease, though, is factors including constipation, prolonged straining, irregular bowel habits, diarrhea, pregnancy, increased abdominal pressure. Thompson has a sliding anal cushion theory. In 1975, he suggested that this hemorrhoid disease was related to stretching of the anal support tissues or downward sliding of the anal tissues, causing from straining and irregular bowel habits, causing inflammation and engorgement of these hemorrhoidal bundles, which then causes to make them prone to stretch when you have hard stools. It's important for the students to pay attention, especially with the difference between external and internal hemorrhoids. External hemorrhoids are part of the distal 1/3 of the anal canal. They're distal to the dentate line. They're covered with anal derm and skin. They're covered with squamous epithelium. And they tend to have symptoms secondary to thrombosis, which is pain and bleeding. Internal hemorrhoids are those that are proximal to the dentate line and covered with columnar or transitional epithelium. And they have symptoms due to bleeding, which tends to be painless, then also thrombosis, strangulation, and prolapse, which can cause pain with internal hemorrhoid disease. There's also 4 grades of hemorrhoids, which has been on a test before. Grade 1, which is a bulging into the anal lumen with no protrusion, which usually results in painless bleeding. Grade 2, which is involved with protrusion during straining and reducing spontaneously. Usually involved with painless bleeding and a palpable mass during defecation. Grade 3 are those that protrude spontaneously and require manual reduction. And involved in painless bleeding, palpable mass, and leakage, as hemorrhoids are also involved in promoting the resting anal tone. And then grade 4 are those that are permanently prolapsed and irreducible. They tend to be involved with bleeding, leakage, and poor anal hygiene. Clinical evaluation for patients with hemorrhoid disease involve a history and physical examination of bleeding, straining, rectal examination, and endoscopy. Bleeding per rectum, even if you see hemorrhoids, you should be cautious. You should also have further evaluation with sigmoidoscopy or colonoscopy so you're not missing a synchronous colon cancer or something like that for those patients. In younger patients, you may consider just doing a sigmoidoscopy, but for older patients, especially those above the age of 50 that come with bleeding, you should also make sure that you look for colon cancer prior to treatment for hemorrhoid disease. When we talk about treatment, in fact, non-operative management for hemorrhoid disease is more common than actually operative management. The first step is to do dietary and lifestyle modifications, increasing fluid and fiber in the diet, exercise, cilium supplementation, and no reading on the commode, which can cause some straining. Medical therapy has really not been shown with any large, rigorous clinical studies to actually to have one benefit one way or another. Sitz baths have been used to provide symptomatic relief. Office-based treatments for internal hemorrhoids can start with rubber band ligation, which is used to treat grades 1 through 3 internal hemorrhoids. Those are the ones that are proximal to the dentate line. The patient is placed in a prone jackknife position with no anesthesia. A slotted anoscope is introduced, and you make sure you have good lighting. Some advocate to ban the largest hemorrhoid group first. Well, some studies have suggested that banning more than one group in the first setting does not portend worse outcomes. You need to make sure you place the rubber band at least 2 centimeters above the dentate line. If the patient has pain, then you must take off the significant pain. You need to take off the rubber band. The patient really returns to normal activities immediately. The rubber band tends to slough off within about 5 to 7 days, as well as the hemorrhoid that is banded. Complications include pain, bleeding, pelvic sepsis, but they tend to be rare. Here's an example of rubber band ligation, where one has a grasper that one puts within the ligator. You grab the hemorrhoid and place the ligator here, and fire the ligator, which then deploys the rubber bands. And you can see here that it's proximal to the dentate line, which is here. Another option is to have a suction ligator, where the suction sucks up the hemorrhoid, and then the rubber band is also introduced. Other office-based treatment include infrared photocoagulation, where an infrared tungsten halogen lamp is used. It's very useful for small bleeding grade 1 and 2 hemorrhoids. The complications tend to be infrequent, causing bleeding, pain, and fissure. Sclerotherapy has also been used, with injection of phenol and hypertonic saline, although results are mixed. You need to inject it about 1 centimeter proximal to the dentate line, but can be used in patients in short or long-term anticoagulation. Here's an example of infrared photocoagulator with a tungsten halogen lamp. Operative hemorrhoidectomy is really indicated only for patients who fail or not candidates for non-operative management. These are patients with extensive disease, those that have concomitant anorectal conditions that will require examiner anesthesia or the patient preference. It's important to note that it's only about 5 to 10% that actually undergo operative hemorrhoidectomy. And there are many different techniques: the Milligan-Morgan open technique, the modified Ferguson technique. Stapled hemorrhoidectomy is the ones we'll talk about. There's also whitehead hemorrhoidectomy, but there are other methods to do the hemorrhoidectomy. Here's an example of the Milligan-Morgan hemorrhoidectomy. It's an open technique. It's used a lot in the United Kingdom. It's excision of the external hemorrhoids with a suture placed at the pedicle, but the defects of the anoderm are left open to heal by secondary intention. The modified Ferguson technique is a closed technique where you similarly excise the external hemorrhoids and the sutures placed at the pedicle, but then the defects are closed using a running suture. Post-operative complications. This operation causes significant pain. That's one major thing you need to counsel your patients on preoperatively. Patients has been found that patients usually don't return back to their normal activities to about 2 to 4 weeks. Urinary retention can be high in these patients, 2 to 36%, but major complications such as anal stenosis, infection, and incontinence tend to be rare. Bleeding is something that's also very important. It has been on the exam several years ago, where bleeding post-hemorrhoidectomy is something that one must pay close attention to. Severe hemorrhage is in about 2% of patients, and Chen and colleagues found that risk factors include male patients and the technique of the surgeon, not what procedure they did, but how they did it. The majority of these respond to packing, but a good amount, 15 to 20%, will need operative intervention. So if a patient comes in with bleeding from post-hemorrhoidectomy, it's not uncommon or not out of the ordinary to have to take these patients to the operating room to do an examiner anesthesia. The last technique is a PPH, or procedure for prolapse and hemorrhoids, which is a circumferential resection of the mucosa and the submucosa above the hemorrhoids and then staple close the defect. Some consider this more of a hemorrhoidopexy rather than a hemorrhoidectomy, involved in sort of grades 2 to 3 hemorrhoids and some grade 4 hemorrhoids that can be manually reduced after patients under anesthesia. Studies have suggested that the PPH creates less pain and earlier return to work and is overall safe. However, there have been several reported complications of this PPH, including perforation, retroperitoneal sepsis, and pelvic sepsis associated with this. As you can see, a special anoscope is introduced, and the purse string anoscope is introduced through there. A purse string is created. and the purse string suture is then pulled through the stapler, and the mucosa submucosa is then taken. The other important thing to talk about with regard to hemorrhoids disease is thrombosed external hemorrhoids, which are painful mass in the perianal region. It's abrupt onset. It is a pain in the ass, for sure. Peaks at about 48 hours, lasts for about 4 days, and the treatment is really to relieve pain. The treatment is guided by the pain of the patient. If the patient continues to have intense pain, you need to excise and remove the thrombus and maybe lightly close some of the anoderm, but leave it open so that he doesn't have recurrent thrombosis. Or improving, a patient that says that we saw a patient, Austin and I saw a patient in Santa Rosa a couple of months ago where the patient said, I had intense pain for the last 4 days, but it's getting better, and I don't really have much pain anymore, but I wanted to come in just because it was still not completely resolved. So in those patients, you want to treat them conservatively with sort of sitz baths, analgesics, and fiber. Here, thrombosed external hemorrhoid. Special considerations in patients with hemorrhoid disease. Those in pregnancy, pregnancy intensifies hemorrhoid disease, and operative intervention should be offered for those patients with acute thrombosis and prolapse. The patient should be placed in left lateral or Sims position in order to keep the gravity uterus off the inferior vena cava. In patients with Crohn's disease, the rate of severe complications are high, and really hemorrhoidectomy should be reserved for those patients with quiescent ileal disease that really have no anorectal manifestations of their Crohn's disease. In patients with immunocompromised state as well, it's also fraught with complications, although anecdotal data suggests that stapled hemorrhoidectomy may be an option in those patients. In studies examining hemorrhoidectomy, a major systematic review looking at 12 randomized controlled trials comparing stapled hemorrhoidopexy with conventional hemorrhoidectomy has found that conventional hemorrhoidectomy has less recurrence and decreased prolapse, and with non-significant trends to postoperative pain, pruritus, and anal stenosis. And in terms of the pain of hemorrhoidectomy, a recent double-blind randomized controlled trial looking at post-hemorrhoidectomy pain using liposome bupivacaine has found a significant decrease in cumulative pain score, opioid consumption, and opioid-related adverse effects. So in summary, in terms of anal abscess, IND is the mainstay of treatment, but be cautious in patients with complex abscesses, such as those with HIV and AIDS and hematologic disorders. Patients with fistula and ano, it's important to determine the type of fistula, lay open if possible. There are variety of techniques to tackle complex fistula disease, but be cautious in those patients with Crohn's and HIV and AIDS. In terms of fissure and ano, start with lifestyle modification, then go to tailored topical calcium channel blockers, and try a tailored versus a traditional lateral internal sphincterotomy. In terms of hemorrhoid disease, it's important to look at lifestyle modification first. Know that about 5 to 10% are those patients that actually undergo an operation, and the operation is literally a pain in the butt. So try to consider liposomal bupivacaine because it's shown to reduce pain post-hemorrhoidectomy. And for patients that have thrombosed external hemorrhoids, the treatment is really guided by their symptoms. So here are the references, and I'll take any questions.
Some patients that don't have a fistula, but they have like a sinus tract where it never perforated out.
Like a blind tract.
A blind tract. Are those treated any differently, or what do you do with those?
You can open, correct me if I'm wrong, I think you can open the blind tract and open that area up. It's what I've seen and I've done before.
Well, we have two professors of holistic medicine here, Dr. Perry, Dr. Ramos.
Very nice talk. Thank you, sir. Just if you on your slide about the priorities for fistula treatment,
right.
I mean, you didn't put them in any kind of rank order.
They're all.
But the most important thing in fistula treatment is to preserve continence. Okay, we have lots of things we can do, but if we get a fistula that's been laid open and is a high fistula and the sphincter's gone, there's not a lot we can do to help that patient. So really, your main goal should be to preserve continence because you have options now for fistula treatment. The other thing is on thrombosed external hemorrhoids, I would really encourage everybody to take to heart that these need to be excised. This is not an incision and pop the blueberry out, okay, because they come and see me because the recurrence rate's about 30% if that's all you do. So you can do it at a local, but it lips it out, close it up, and they do a lot better.
So,
Dr. Ramos, what about Crohn's disease? And we briefly touched on it as far as the fistulas that we see with those people. Are you going to cure any of them if they still have active disease, or are these fistulas coming from the small bowel or the colon?
You cannot cure Crohn's disease. It's an incurable situation, but as he said, you need to palliate the symptoms, and you need to preserve continence to a degree. And sometimes the patient may show up with these problems already incontinent. They're incontinent not so much because the fistula and the abscesses have destroyed the sphincter, but because of the lack of compliance of the rectum. They get stenosis and they get increased compliance, and therefore they're incontinent.
So you should be conservative.
It's very conservative. We have patients that have a C-tone for a couple of years, and you don't want to do anything else for them. You don't want to do cutting C-tone. Certainly, that is not in my armamentarium. I have seen the evolution of new methods for fistula treatment, but I still believe that to cure the fistula, you have to get rid of the tract most of the time. Lift is a very promising technique, and we've been using it probably at the university hospital. We have done 5 of these procedures out in the practice. We have done similar numbers. We have really been disappointed by the plot. How much does the plot cost? $800?
Is it?
Yes. Very, very expensive, and 50% is a number that is questionable because you have not enough follow-up on months of follow-up. So that is something that was at the first publication 80-90% success rate, and then it decreased rapidly. The rule that you had to preserve 1/3 of the sphincter muscle to get continence is still very valid. And that was proposed by an Egyptian surgeon by the name of Shafi that had a special model of sphincter mechanism with 3 loops. So you can take 2 loops of that mechanism, and you can preserve the pure rectalis. You have very good continence. Those are very difficult problems. And again, if you have a fistula where you can see the primary opening, the secondary opening, and you can feel the tract, there is no reason whatsoever to order CT scans, MRIs, ultrasounds, fistulograms, etc., etc., etc. That is, or anorectal. That is just increase the cost tremendously, and it just talks of the ignorance of the head that is ordering.
so I got several questions. Some of these tie into the comments that were just made. So if you've got a high fistula, okay, and your options are cetons, the plug that we just decided probably
flap,
isn't that great,
advancement flap and lift.
Advancement flap and a lift. What's the best choice today? And in the emergent setting, someone comes with an abscess, you drain the abscess, and you recognize a high fistula at that time.
You just drain the abscess.
Just drain the abscess, and then you'll see them back after the abscess is drained and cooled down, and
then
6 weeks, 12 weeks, still have a fistula. Then what?
Then I would, looking at the data, depends on which lift. I mean, you can look at which lift data one can see. You can see that some lift data, at least short term, said 90% success rate, while others said about 50%. I think that's an option. I think if you need to also evaluate that patient with a good history and physical to see if they have any signs and symptoms of inflammatory bowel disease, because then your treatment options are going to be different. If you have a history of Crohn's disease, or you determine that the patient has Crohn's disease, you may consider just putting a ceton to the fistula and controlling the infection first. and then just leaving, like Dr. Ramos said, just leaving it in and not being aggressive with those patients. But the patients that have cryptoglandular related disease, I think a lift is a good option. I think if you have good, I think from what I've seen, folks use lift, and I haven't seen many advancement flaps personally. Maybe I can defer to my professors,
Your senior colleagues.
my senior colleagues about that specifically.
So again, it all depends on the location, patient's continence and whatnot. So the way I'd like to look at it, again, like Dr. Ramos said, if it's only about half the external sphincter, then I'm using a cutting ceton on this. I've had good success with that. If it's longer, and what you can do in the case of an acute abscess, if you do identify the internal opening, go ahead and put your place-holding or your non-cutting ceton in there, because then because the chance of them healing that without a fistula is almost zero if you see an internal opening at time of abscess drainage. So put a place-holding ceton in, make it snug but not tight, and that'll shorten the length of your fistula. Once everything heals in behind it, and then once you have that in place, that's a good one for a lift, because you've got a well-defined tract and you've got a ceton through there, so you can go down and do your lift procedure or your plug.
All right. Next question. Patient presents with the classic signs and symptoms of a fissure, and you're asked to see him in the emergency room. All right. If you can get a good enough exam and become convinced it's just a fissure, do you just start them on conservative treatment and send them home? Or I've heard some people advocate for anybody who comes to the ER and their rear end hurts enough to sign a consent form. You sign them up for an exam under anesthesia and don't torture them in the emergency room.
Well,
and then if you find a fissure in the OR, it's kind of hard to not do the sphincterotomy when you're there with the instruments. But do you not do the sphincterotomy and treat them conservatively? So what is the ER treatment for someone who presents with a fissure?
I would treat them conservatively, and if you find that they have a fissure, I would, in a patient that hasn't had an attempt at sitz baths and things like that, then I would not do a sphincterotomy at that time, because you still have up to 5% risk of incontinence or worsening incontinence in those patients.
Just piggybacking on that, incontinence, are there any long-term data? Because I would guess most of these continence data are short-term. When you're doing on a 20 or 30-year-old patient, the question is not, are they going to be continent when they're 35? The question is, are they going to be continent when they're 75?
I don't know.
Yeah, we did the practice parameter for fissure, so we looked at that, and the long-term data is very good for a properly done fissulotomy. Out to, I think the longest study was 15 years. And so they're actually, for appropriately done sphincterotomy, the risk of continence is low and does not tend to decrease over time. And so they've actually looked at that. I did not find anything that suggested that open and closed were any different. I think the meta-analysis did not show much difference between open and closed sphincterotomy long term.
There was, I'll have to get it, but there was in the chapter they suggested that there were several studies that.
Remember how chapters are written. Who writes chapters? People with opinions. So.
Dr. Ramos. To answer Dr. Dent, the question is that in a very tender, painful hands, you do not do a digital exam. Number one is that you do a very careful inspection. And by doing a careful inspection, then you find the fissure, and then you treat the fissure. And that means spreading the cheeks, having a very good light, not be shy, and you just look at it without introducing the finger, because that's what it hurts. And you can see that fissure, you can see the telltale of the sentinel tag. You can put topical anesthetic, and then you can palpate around the anal canal to be sure that you don't have an abscess, because that's where you feel I'm missing an abscess. Now there's some intramural abscess that you cannot detect this way, but if you can see a fissure, then you need to treat it medically with oral analgesics also send them home and follow up. I don't think you need to take. I don't remember when I took the last fissure to the operating room as an urgent procedure.
Dr. Estro, we were talking about anorectal disease in immunocompromised patients. We know we see diverticulitis and we see cholecystitis, but do you have to deal with any of this or see it develop in your immunocompromised transplant patients?
I can't remember the last time we've even seen benign anorectal disease in a transplant patient. It's a rare problem.
Last question. Should we be doing more or fewer hemorrhoidectomies? Because in terms of the pain and discomfort, it's high with hemorrhoidectomy, but in terms of the recurrence rate and actual treating the disease, I realize it doesn't cure it in the sense that you do a hemorrhoidectomy on a 30-year-old, they may very well have bad hemorrhoids 10, 20, 30 years later, but it sure cures it for at least the next 5 to 10 years typically. Should we be doing more? And along those lines, you mentioned like photocoagulation for grade 1 and 2 hemorrhoids in the clinic. Should we be doing more earlier? And is this an opportunity for surgeons to have a lower threshold to do surgery and cure diseases or cure the patients better? Or is this got enough morbidity that maybe we should be doing fewer? Because the traditional teaching is the indication for a hemorrhoid is scabs, with the scabs being on the patient's knees from begging for the operation for so long, they've got scabs on their knees. And I don't know that making patients suffer that long is the right answer, but...
I think that since we have newer methods of postoperative pain control, you should still follow the same algorithm. But waiting, obviously my experience is limited to only a few years, but I would say that if the patient, you don't wait, you may not wait as long after the same treatment if they're actually following through with the diet and lifestyle modifications. I mean, I think if you're able to manage their pain better with this sort of liquefied bupivacaine, I think it probably warrants you to operate maybe a little earlier for those patients. I would say of the 5 to 10%, maybe you'd go up to maybe 15 to 20%. I wouldn't say that still the majority of the patients should be treated with diet and lifestyle modification. Is what I would say. But what do I know?
Again, it's a spectrum of disease. If you're doing a Ferguson hemorrhoidectomy for grade 1 hemorrhoids, that's the wrong thing to do. If you're trying to do lower-band ligation for a giant rosette of grade 3 and 4 hemorrhoids, you're not going to get anywhere. So again, you tailor it to the amount of disease. Certainly, you can. At this point, I can basically tell them when I see them whether I'm going to get them better with banding or not. But that's the patient with the large, 3-column internal-external complex. We're going to get them better quicker with an operation. I'll offer them that up front. But those patients are fairly uncommon.
Two other varieties. The patient that is pregnant or just after delivery, they have huge thrombosis. And the patient that comes in with anemia, profound anemia secondary to bleeding. And that those patients, if they're not, they don't have portal hypertension, I think the one with anemia needs hemorrhoidectomy, the other one can have conservative treatment.
And I had a good success with the infrared coagulator. It's a good option on patients that are on Plavix, and even kind of low-grade Coumadin, because you can do that in the office without stopping their anticoagulation.
Stuart? So I don't think you mentioned Ethicon Endosurgery. Speaking of expense, Ethicon Endosurgery recalled their stapler 2 weeks ago for safety concerns, including, the report says can cause death, so I assume there were some significant problems with it.
I got a call from Monterrey the other day on a patient that had the wife of the plastic surgeon had one of these procedures, and the next day she had crepitus in her neck. For perforation.
So you didn't advocate for it, but I would be stronger in my condemnation of it.
Not in my toolbox anymore.
You can't use it right now.
Right.
Well, you have the other one, the comedian, and we used it last week on a patient that had portal hypertension.
Closing note, Dr. Stewart assured me that it was pure coincidence that we picked this topic on the anus the day before election. Thank you.